Yeah, so we are ready. You can start. I'll mute myself. And so we welcome Dr. John Davids from Sacramento for his talk on management of upper extremity in children with cerebral palsy. Over to you.
Thank you, Taral. It's a pleasure to be participating in this program and to give this lecture. The title is Management of the Upper Extremity in Children with Cerebral Palsy, Clinical Decision-Making and Outcome Assessment. These are my disclosures, none of which are really directly relevant to this particular presentation. What I'd like to do in the presentation is seen here. I will begin by contrasting the role of surgery for the upper extremity in children with cerebral palsy relative to the lower extremity. Then we'll discuss clinical decision-making for single-event multi-level surgery of the upper extremity, utilizing a diagnostic matrix that includes the Shriners Hospital Upper Extremity Evaluation, or SHU. I'll then share with you indications and preferred techniques for some of the common operations that we do at the wrist and the thumb, and then finally share with you some outcome studies that we've done using the SHU, looking at outcomes in following upper extremity surgery in children with cerebral palsy. So the upper extremity, like the lower extremity, deficits and deviations can be considered primary, secondary, or tertiary. Primary deficits include those related to spasticity, balance, and sensibility. Secondary deficits or deviations are related to contractures and skeletal deformities. Tertiary deficits or deviations are actually compensations for primary or secondary problems. Unique aspects of the upper extremity relative to the lower extremity are that its movements are less constrained. The upper extremity is not obliged to interact with the floor like the lower extremity, so there are not the energetics limitations to motion. The upper extremity has more levels of multiplanar motion than the lower extremity, which creates complexities in terms of measuring that motion. And then finally, hand function is more complex than foot function. And here we're talking about the distinction between gross motor function and fine motor function. One of the largest or biggest challenges in the upper extremity is determining what is normal. Previous studies looking at task completion in a group of typically developed individuals utilizing dynamic electromyography have shown that there are multiple patterns, movement patterns, and EMG activation patterns utilized by typically developed individuals to achieve the same task. If we can't define what is typical or normal, it makes it very difficult to define deviations from normal. Finally, as we have learned in caring for children with unilateral congenital below elbow deficiencies, it is possible to have very good function with only one completely functional present upper extremity. This leads to neglect of the involved upper extremity from an early age, which creates further functional deficits. Cosmesis is a very important element of the upper extremity. In our Western cultures, the typically exposed parts of the body, the face and the hands, have been shown to play a significant role in first impressions. Cosmetic problems then associated with the upper extremity can have significant psychological impact, particularly during the teenage years where self-esteem can be compromised. There may be significant hygiene issues in the upper extremities associated with the more severe deformities, such as the thumb and palm deformity, extreme finger flexion deformity, extreme wrist flexion, and extreme elbow flexion. In our approach, treatment options for the various levels of deficits or deviations are seen here. Primary deficits and deviations are best treated with developmental therapies, perhaps neurosurgery, rhizotomy, or intrathecal baclofen, and then pharmacotherapies with baclofen and or Botox. Secondary deficits or deviations are best treated with orthopedic surgeries on the muscle tendon units and on the skeleton, and the use of orthotics. Tertiary deficits or deviations will resolve spontaneously when the primary or the secondary problem is addressed. If we look at age on the horizontal axis and consider the frequency of the various treatment options on the vertical axis, we see that developmental therapies are most appropriate in the early years. We see Botox as primarily a bridge therapy to get from younger age to an older age where more definitive interventions can be performed. Finally, there is a bimodal peak for orthopedic surgeries, the first occurring in late childhood, consisting primarily of soft tissue surgeries, tendon lengthenings and transfers, and the second occurring near the completion of skeletal growth, which involves arthrodeses of the wrist and the thumb. The underlying rationale for single-event multi-level surgery of the upper extremity is to identify all the functional deficits and address them in a single simultaneous surgery. The benefits to this approach are that the multiple surgical procedures can be performed at the same setting. This is followed by a single period of immobilization and a single period of rehabilitation. Clinical decision-making integrates information from a variety of domains. This includes a careful clinical history in which the patient and parents' perspectives are understood. The physical examination helps us sort out dynamic versus myostatic malalignments. Diagnostic imaging is fairly limited, usually just to determine skeletal maturity when considering arthrodeses. Finally, the exam under anesthesia may be helpful, again, in determining how much deformity is dynamic and how much is fixed or myostatic. In the clinical history, we focus on activities of daily living and the goals that the child and the family may have. We now have more sophisticated patient-reported tools that help us do this. The physical exam looks carefully at range of motion, strength, selective voluntary motor control, spasticity, and sensibility. Plane radiographs, as I mentioned, are used primarily to assess for alignment and skeletal maturity. The exam under anesthesia helps us sort out the type of muscle tendon deformity that we are dealing with. This is a picture of my mentor, Dr. David Sutherland. He's remembered primarily for his contributions to gait analysis for children with a variety of diagnoses, including CP. But he also had a big interest in the upper extremity. He tried a lot of different approaches, but was constrained by the technology available to him. He tried to develop a kinematic system using marker sets and electrogoniometers. He dreamed of upper extremity kinetics, but had no way to get it. He finally focused on an approach utilizing dynamic EMG. This involved the measurement of the activity of multiple muscles using fine wire electrodes, which were inserted into the muscle bellies. This is the output that he generated with his approach. In this screen, we see a subject. The examiner is showing the subject what she would like the child to do with his hand. The child then moves his hand or upper extremity, and it's possible to see, in this particular case, 4 channels of EMG activity. This approach is technically challenging. It involves some expertise in placing the electrodes in the muscles. The subjects typically don't like having this test done because it involves multiple needle sticks. And the approach in the end was utilized at only a few centers around the world, and getting follow-up in this approach was always quite limited. Again, because the patients really didn't like doing the study. If you can't get the follow-up, really the whole paradigm falls apart. And so this approach never really caught on. What the future holds is the use of an upper extremity kinematic model, and there are many models out there which involve placement of some type of a marker on different bony landmarks on the different segments of the upper extremity. A lot of work has been done on this recently. Just a few years ago, there was a whole section of the American Academy of Cerebral Palsy meeting dedicated to quantitative assessment of upper extremity function. In the absence, though, of a fully developed upper extremity kinematic model, we developed a tool to help guide clinical decision-making and outcome assessment called the Shriners Hospital Upper Extremity Evaluation, or SHU. The test looks at spontaneous use of the involved upper extremity and scores it with a modification of the house score. And then the test, heavily influenced by our experience in lower extremity motion analysis, looks at potential use of the affected upper extremity by assessing dynamic segmental alignment during the performance of functional tasks on demand. The SHU has been validated and was published in this article in 2006. There are extensive training materials available, and they can be found on this website. The SHU, to the best of our knowledge, is utilized in over 20 countries around the world and has been translated into German, French, Spanish, Portuguese, and Turkish. This tool is qualitative. It is subjective. It requires a significant amount of training to achieve proficiency. And we really have quite a bit more to learn about the objective measurement of upper extremity function in children with cerebral palsy. It's an exciting area, but also a very challenging area. The SHU is a video-based test. It takes about 15 minutes to perform. It's scored later. The scoring takes longer than performing the test. It becomes part of the subject's medical record, and we use it to guide conferences with a multidisciplinary team for clinical decision-making and establishment of a plan of care. The tool uses 14 inexpensive, easily obtained items and 16 tasks that were selected to look at specific movements and function of different segments of the upper extremity. The test measures spontaneous functional analysis, as highlighted here. The concept underlying spontaneous functional analysis is that it represents the degree of neurological impairment present. The concept is that a lower spontaneous functional analysis score would be associated with less functional improvement following interventions. This is a concept that has yet to really be fully proven. The second part of the SHU looks at a series of 16 activities that were selected to determine the potential or actual alignment of the segments of the extremity when performing these tasks. The dynamic positional analysis looks at thumb alignment, finger alignment, wrist alignment, forearm, and elbow. The 4 tasks for each of these anatomical areas are used. The concept underlying the dynamic positional analysis is that the alignment during the performance of functional tasks can guide us in selecting the appropriate surgical intervention. The third part of the SHU is the grasp and release analysis section, which looks at the relationship between finger function and how it is affected by wrist alignment. In this section, we also look at static thumb alignment and stability. With this approach, then, it has become possible to develop specific indications for the most common procedures performed at the wrist based on input from physical exam, in some cases X-ray exam, and then the SHU, including analysis of the spontaneous functional analysis portion of the test, the dynamic positional analysis portion, and then when appropriate, grasp and release. So there's indications identified now for the wrist, the thumb, the elbow, the forearm, and the fingers. Let's look at a case that illustrates many of these points. This is an almost 8-year-old boy with left hemiplegic or unilateral cerebral palsy. He previously had undergone constraint-induced therapy, Botox, and orthotics. His mother was quite aggressive in pursuing care for his upper extremity. He had no previous surgeries, and the family was interested in improving function. His physical exam is shown on the screen. his left upper extremity passive range of motion was complete at the elbow, minimally limited at the forearm, minimally limited at the wrist. Fingers had full passive range. The thumb showed some limitations, and the thumb MCP joint was unstable. Tone assessment showed low tone. The video here shows the fairly typical posture of an upper extremity in an individual with unilateral cerebral palsy. The elbow appears to be flexed, the forearm appears to be pronated, the wrist appears to be volarly flexed and ulnarly deviated, and the child has a thumb and palm deformity. The initial shoe analysis showed a spontaneous functional analysis score of 67%, with almost all activities occurring in the active range. This suggests relatively minimal underlying neurological impairment, and also suggests that if we can improve the alignment of the upper extremity, the child should be able to use it to improve function. The dynamic positional analysis total score was 76%, with deficits appreciated at the thumb, to a degree at the fingers and at the wrist. This guides us in targeting thumb and wrist for interventions. Grasp and release total score was 100%, indicating the ability to perform grasp and release with the wrist in all positions, suggesting that once the wrist alignment was corrected, we would not be unmasking problems with the fingers due to extrinsic finger flexor tightness. The child underwent single event multi-level surgery for the left upper extremity. This included an FCU to ECRB tendon transfer to improve wrist alignment, thumb web release, thumb MCP joint stabilization with sesamoid capsulodesis, and an EPL rerouting. 15 months after surgery, the child and the family noted many improved functional activities, as you see on the screen. The physical exam showed maintenance of range of motion at the elbow, slight improvement at the forearm, slight improvement at the wrist, and improvement at the thumb with MCP stability. The follow-up video shows that the wrist is in a fundamentally different position, as is the thumb. On the top, we see the preoperative score. On the bottom, the postoperative score. Spontaneous functional analysis improved from 67 to 78%, and more of the scores at the follow-up were in the higher level active assist. Dynamic positional analysis total score improved from 76% to 96%, with the two targeted areas, the thumb and the wrist, showing the desired improvements. Grasp and release score remained 100%, indicating that the child was able to perform grasp and release with the wrist in all positions, confirming our decision-making for this element. So in looking at this case, and considering outcomes in the technical domain, the improved dynamic positional analysis and improved static and dynamic alignment support the technical domain outcome. In the functional domain, the child showed improved spontaneous functional analysis, which is really the ultimate goal of all of this, is to have the child use the hand more spontaneously. And then in the satisfaction domain, the family were pleased and wanted to do it again. As we look at things a little more carefully, though, and consider the functional domain, it's very clear that the child may have achieved improved gross motor function, but that fine motor function, proprioception, and motor control deficits remain. These are impairment elements that are not addressed by the upper extremity surgeries that we perform, and it's very important that the families understand this during the shared decision-making process for surgical, when considering surgical intervention. Let's look at a few common procedures and go through the indications and outcomes. When considering flexor carpi ulnaris to extensor carpi radialis brevis transfer, the indications within the framework of the shoe are a spontaneous functional analysis score of 3 or better. That means the hand is functioning at least as a poor active assist or better. The dynamic positional analysis score should show consistent wrist volar flexion and ulnar deviation. The grasp and the release section should show the ability to perform the perform grasp and release with the wrist held in a corrected position. If this is not present, then consideration for intervention to the extrinsic finger flexors must be made when considering performing the tendon transfer to improve wrist alignment. The technique that I like involves incisions on the volar aspect of the forearm and on the dorsum of the wrist. I do not think that this operation should be done with small incisions because of the anatomy of the FCU, which has its muscle belly going very distally. I follow the principles of tendon transfer developed in other types of upper extremity surgery, selecting muscles that have appropriate strength and excursion, tunneling them through a path that minimizes scarring, tunneling them through, or releasing them to a degree that the path of or line of pull is as straight as possible, transferring the tendon at a level that minimizes scarring. That means typically in a fatty plane. And then tensioning the transfer so that the muscle's tension is slightly greater than it would be at rest. So here we see on the top the dorsal wrist incision showing the FCU brought around and sewn into the ECRB. The bottom image shows the desired tensioning of the transfer, which is the wrist extended approximately 10 degrees against gravity. Here is a typical case. This is the preoperative shoe video, which shows the wrist in the volar flexed and ulnarly deviated position. The child met indications for FCU to ECRB transfer. He also had a thumb reconstruction, and here is the result. And again, the wrist position is fundamentally different following this transfer. The hand is in a more functional position following the FCU to ECRB transfer, which augments wrist extension. Let's move on to wrist arthrodesis. The indications for this procedure include a spontaneous functional analysis score of House 2 or worse. This describes more impairment and function of the upper extremity, primarily as a passive assist. The dynamic positional analysis should show the wrist to be consistently volarly flexed and ulnarly deviated. Grasp and release shorts assessment should show at least passive finger and thumb extension with the wrist held in the corrected position. If not, then consideration for extrinsic finger and thumb flexor lengthenings should be made at the time of wrist arthrodesis. The approach that I favor is a dorsal incision. In this image, we see the hand at the bottom and the elbow at the top. The U is the end of the ulna. The R is the distal radius. The procedure exposes the proximal carpal row. Typically, this shows some degenerative changes from abnormal loading. The proximal carpal row is seen in the circle. The proximal carpal row is excised, and the articular cartilage is removed. The excision of the proximal carpal row achieves skeletal shortening, which can help with functional soft tissue lengthening. There are a variety of implants that can be used. The least expensive is a simple compression plate, which has to be contoured. There are pre-contoured plates that exist, and plates that use smaller screws distally than proximally all work quite well. The final position that I like is with the wrist slightly extended and slightly ulnarly deviated. I think this is the most natural looking position. Here's the case of a child who showed the typical wrist volar flexion ulnar deviation deformities. In his case, I felt he was actually a candidate for either tendon transfer or wrist arthrodesis. He was a high school senior, and after learning what was involved with each of the procedures and what the expected outcomes would be, chose to have the wrist arthrodesis. He was interested primarily in cosmetic result and was satisfied with his current level of function, which I counseled him would be somewhat improved by doing the wrist arthrodesis. And here's his outcome following surgery. Overall alignment is good. his measured functional performance was slightly improved, and he was very pleased with the cosmetic result. Thumb reconstruction is complex. I would say this is the most difficult area for decision-making and outcome assessment in upper extremity surgery for children with CP. The principal issue is whether we are performing a functional or a cosmetic hygienic type reconstruction. The indications are a spontaneous functional analysis of House score 2 or better if we're hoping for a functional improvement. The dynamic positional analysis score typically shows a thumb and palm deformity with a tightened web space. Grasp and release analysis allows for assessment of tightness of the web space, thumb MCP stability, which is almost never present. Hyperextension instability is very common. And then the magnitude of the deficiency in extension and abduction. There are a variety of approaches that have been described for doing thumb reconstructions in children with CP. I favor a single incision dorsal approach centered over the thumb MCP joint. Through this approach, it's possible to perform a complete release of the adductor pollicis and first dorsal interosseous from the thumb metacarpal. In my experience, it's much more common to underdo this portion of the procedure than to overdo it, so I perform a fairly aggressive release. The EPL tendon is then transected distally, brought into the proximal incision, and then rerouted from the third extensor compartment to the first compartment. This results in a straighter line of pull of this tendon, which puts it at a biomechanical advantage for performing palmar radial abduction. The MCP joint is then exposed if the child is scalically mature. The articular cartilage is removed, and a variety of fixation options are available. In the past, I relied primarily on pin fixation, as you see here. There are now implants that are appropriately sized that can be placed, plates and screws, that also function quite well. After performing the web release and the MCP arthrodesis, the EPL is rerouted and shortened to create, at a minimum, a tenodesis effect if there is impaired selective voluntary motor control of the EPL. So here's an expected outcome here. We can see very significant thumb hyperextension instability, which compromises holding large objects. Following, in this case, a wrist arthrodesis and a thumb reconstruction as described, you can see that the thumb web space is much wider, the MCP joint is stable, and the child can do a much better job holding a large object. Now, we've been able to use the shoe to perform outcome assessment, which has greatly improved our ability to perform clinical decision-making. Let me share with you just a little bit of the work that we've done. First, looking at thumb reconstruction outcomes. We performed a retrospective case series of children with unilateral CP who underwent thumb reconstruction and had pre- and post-operative shoe analyses. There were 33 children in the study cohort. We first looked to compare preoperative static versus dynamic alignment, and not surprisingly found that dynamic alignment was significantly worse than static alignment. That's why it's important to perform a dynamic assessment. When we looked at pre-op versus post-op, static and dynamic alignment outcomes showed comparable improvements. However, when we defined an optimal outcome alignment, static alignments improved to the optimal level in 82%, whereas dynamic alignments improved to the optimal level in only 61%. So again, dynamic outcomes are much more complex, but are more closely related to function. Finally, we looked at the change in spontaneous functional use relative to the change in dynamic alignment and found a poor correlation. This suggested that no matter how neglected the extremity was, we were able to achieve comparable improvements in dynamic alignment of the thumb. This was not the outcome that I was expecting and really draws into question the assumption that greater impairment relative to spontaneous functional use predicts less improvement following surgery. Another important study we did looked at overall outcomes following single event multi-level surgery of the upper extremity in children with unilateral CP. Another retrospective study, here we had a case and a control series. There were 40 cases, children who had upper extremity interventions with pre and post shoe studies documented. As the control group, there were 26 children with unilateral CP who had 2 upper extremity studies, but no upper extremity interventions in between. In all of these cases, the children had lower extremity surgery done as a priority, and then came back, had a second shoe, and then had the upper extremity surgery done. So this allowed us to compare a non-operative group to an operative group. The groups were comparable relative to the pre-upper extremity intervention shoe relative to spontaneous functional analysis, dynamic positional analysis, and grasp and release. In the non-operative group, there were no significant changes between the initial and the second upper extremity evaluation. There were no interventions in between this. So nothing really changed. There was no improvement, and in this period, no deterioration. The operative group showed statistically significant improvements in spontaneous functional analysis and dynamic positional analysis, and no change in the grasp and release analysis. Our interpretation was that the improved dynamic positional analysis was both statistically and clinically significant. So the surgeries were effective in improving the alignment of the targeted segments. With respect to the improved spontaneous functional analysis, although the improvement was statistical, it was really quite small. And I question the clinical significance of this. Further work needs to be done establishing the minimal clinically important difference for the shoe, and certainly a larger cohort to better understand whether we actually can improve spontaneous functional analysis with these surgeries. The stable grasp and release analysis scores validated the clinical decision-making process for relating wrist correction to the need for finger flexor surgery. So trying to wrap all of this up, the Shriners Hospital Upper Extremity Evaluation is a clinical tool that provides structure to clinical decision-making and outcome assessment. It can complement a variety of other tools, as shown in this recent article that looked at the outcomes of upper extremity surgery in children with CP, utilizing a standardized approach to determine eligibility for surgery, shared clinical decision-making, and very clear outcomes, goals and expectations for outcomes. The shoe will, in my mind, someday provide a framework for eventual quantitative analysis of the upper extremity. There have been some interesting approaches to quantitative upper extremity assessment. The group from Stanford proposed the creation of a grasp and release cycle modeled after the gait cycle. This is interesting, but I really am not sure that it will be granular enough to provide insight into deviations and promote clinical decision-making. There are other studies utilizing motion capture for upper extremity function. They typically focus on fairly routine tasks. And I think that if this technology was used in the framework of the shoe tasks, we would be further along because the shoe tasks have already been linked to interventions and outcomes. It's important to recognize that this tool really only addresses the body functions and structure components of the ICF model, and that attention to activities and limitation elements are also quite important. So in complete summary, or final summary, there are a variety of treatment options for the upper extremity in children with CP. We can do some technically very cool surgeries. But to improve what we do, we need to have better understanding of the biomechanics of upper extremity function. improved ability for quantitative assessment, a commitment to consistent data-driven clinical decision-making, and a commitment to objective outcome assessment in multiple domains. In my career, I have found the upper extremity to be an important area for children related both to function and cosmesis, and have learned that proper patient selection with properly performed surgeries can lead to predictable outcomes, which has been satisfying not only for the physician, but also for the child and their family. Thank you for your attention.